introducing Dr. Anna Podlasek from the University of Nottingham, and she is going to present the data and the analysis that you did, the meta-analysis on whether we should use balloon-guided catheter versus non-balloon-guided catheter in mechanical thrombectomy. Very big debate about interventionless balloon, yes or no?
First of all, welcome everyone, and big thank you to Professor Petrov for bringing us back together again, all of us in Sofia, and it's good to be back in Sofia. So the work, the meta-analysis that we did is on balloon guide catheters, but it was very humbling to observe the whole revolution in this endovascular stroke treatment that happened since 2015. There is a lot of small questions in this big equation of how to achieve a good outcome and successful reperfusion. And we have multiple techniques that can help us to revasculate the vessels. There are three main techniques that I want us to be aware of. So the first one is the Stent Retriever. When we put a retrievable stent into the vessel, the clot is engaged in there and then we retrieve it mechanically. The other technique is aspiration, when we just go with a little vacuum cleaner to the vessel and we just take the clot out. And then there is something which is initially was called Celumbra technique, but it's also called combined technique, and there are a lot of variation as a protect and a lot of variation in this technique, which there are both uses of aspiration and Stent Retriever. So on top of those three ways of taking the clot out, the next addition to our equation is the balloon guide catheter, which is just a small balloon that is pumped up in the moment that we are taking the clot out. It is just for a couple of seconds. And it is hypothesized that it offers proximal flow arrest if placed in the internal carotid artery. And it's supposed to decrease the chance of clot disruption and making sure that all the particles are coming back to us, to the catheter, and we are getting all of this. It works perfectly in the models, but in the human studies, it has inconsistent evidence. Some studies says it's better, some says that there is no difference. Obviously, there are certain limitations with this big guiding catheter. It's much harder to navigate through vessels, so with this big catheter, and not all of the devices are compatible. And also now when the radial access is gaining a lot of interest in mechanical thrombectomy, balloon guide catheter use is quite limited due to the size. However, there are also appearing new players on the market that could enable that. So what we did is that we had a proper look into the literature to see what is currently known, and not only on the balloon guide catheters, but in the context of the technique as a first-line technique that was used in the particular procedure. So we've reviewed almost 9,000 studies. That was a long, long time that we sat in front of the computer. But in the end, we found 16 studies. None of them was randomized, so they were all observational studies or registries. And out of 5,500 patients, we looked at those who had procedure with balloon or without balloon, with Stent Retriever first approach, combined approach, or aspiration. And unfortunately, the bias in the study is that the vast majority of this observational study had a moderate bias due to the non-randomized nature. And this is the biggest summary. So whenever you can see the arrow, it means that, yay, we have statistical significance, so the evidence can be trusted. Wherever you can see an A, it means that there was no enough data to tell anything. And with minuses, there is no statistical significance. So we can see that overall, when we are looking at balloon guide catheter, it gives us everything for us to achieve better clinical outcomes and less mortality. So from the procedural point of view, we have a higher fast effect, we have higher successful reperfusion rate, which is TK2B to 3, and shorter procedural time, shorter number of passes, and shorter distal or new territory emboli. And we can see that this is mainly driven by the Stent Retrievers. And the evidence in combined contact aspiration and combined technique is not that obvious yet. So just looking a little bit in more details in the successful reperfusion, we can see that Stent Retrievers gives us a clear benefit as well as aspiration. But for the combined technique, we don't have yet the evidence. It is the question, does it work, or is it just not simply powered enough because the numbers for the combined technique is a little bit lower than the others. Also, the first pass effect, which was defined as T2B to 3 with the first pass achieved, is also better with the balloon gate catheter. It goes the same also, so it's good to see that those procedural features are translating into the long-term clinical outcomes. It was assessed always at 3 months, so good clinical outcomes, functional independence. And there are also lower rates of symptomatic intracranial hemorrhages and lower mortality. So, as I mentioned previously, there are certain limitations to the interpretation of this data. So, the studies are mainly non-randomized studies. We are still waiting for the first study to really randomize balloon versus non-balloon guide catheters. And there were a little bit of difference in the baseline statistics, a little bit of different diseases. There's also a big question in this could be where the clot was. Was it a tandem occlusion? Was it not a tandem occlusion? And the results were not reported by this, so the analysis for that was impossible. And also, not a lot of study commented upon where the balloon was placed and how well was it inflated. And there is impossible assessment of distal embolization. So, in conclusion, as far as we are at this stage, balloon guide catheters achieve shorter procedural time, and all of this, it goes to the better clinical outcome. Thank you for your attention, and any questions?
Yes. I have one question. I'll ask it to you and to Iris. Does the morphology of the thrombus on your preoperative CT or MRI play a role in your choice whether you would use a balloon-guided catheter or not? For example, especially in bridging therapy, it's known that if you have a red thrombus, you have a dense mediasine, and you have thrombolysis first, and then you start doing thrombectomy, it's known that the thrombus is smashing into small pieces, and then if you don't have a balloon, the risk is higher. Did that play a role in your...
That is an excellent question. I think it is the new topic to go towards, I'll call it precision medicine in patients, so that we can at the beginning already choose the right technique and the right device. As a very simplified way, it seems that if you have a hyperdense MCA, that this is a clot that is more thrombus rich. So more red thrombus. Yeah. And with the red thrombus, it is also then that is more likely that you will be able to get it out in one go, but also that is more likely that you'll have more distal emboli and things that will flow in the periphery. Whereas with the white clot, with the white thrombus, it is more sticky, more gooey, it will more stay together. I think, and I know that the group in Buffalo at Nancy Dickey, they were also looking at a new feature. They are looking at the contrast-enhanced angio in an early and in a late phase. And if there's already some contrast going into the vessel, they see that the vessel is, that the thrombus is more permeable, so more towards red thrombus. So, if I had the choice, first of all, I do believe that using the balloon guide will achieve better results using a balloon catheter. So ideally, one would use it in most cases. If I didn't have the choice, I would use it in the red clot, where I would think that it is much more likely that something is going to lodge off, yes. But in the future, that is going to be a really good topic of research, also with MR, what is the clot composition? I don't know if you've seen it as well with COVID, the clots were quite different, very different composition of clot in those patients, very sticky, very difficult to get out in one go. Sometimes we now use sort of tweezer devices to pull it out. So yes.
Also, like you, I use balloon in all cases.
And a balloon, I would say. So I would be a bit cautious, because one thing we have to consider is many of those studies, when there was comparison, were done by very, very experienced centers, like the center in Essen, René Chapeau, so very big volume centers, gods of intervention. And sometimes in the beginning, it is more difficult getting an 8 French guide up. So I think we will need to make a decision on what does the arch look like. Absolutely. If we do not manage to succeed and get into the vessel, it is no use trying with that. I think we need a sensible approach. And Anna, if I could ask you another question, that is about, do you think that new techniques, like you were showing the Salumbra technique, where you can bring a 5 or 6 French aspiration catheter right up to the thrombus, do you think, did you find anything on that? Do you think that will change the way we perceive it?
So at the moment, there's no evidence for combined technique and use of balloon guide catheters, most probably due to the low numbers. But there are planned randomized trials in this aspect to have a look whether the inflation of the balloon will work or not. We'll lead one in Nottingham, so hopefully we'll have some evidence over the next 1 or 2 years.
Fantastic. Thank you very much.
Yes, and you, Iris, have already pointed out there might be some problems. Yes, first, type 3 aortic arches to bring up the device. Then I only want to mention, yes, you have to place the balloon in the internal carotid artery, not in the common, because when it's in the common, you do aspiration. Absolutely. Get only the blood from the external carotid artery. That's also important. And when you have a very elongated carotid artery, especially internal carotid artery, it's not so easy to place the balloon. So when it's not possible technically, then you have to go on without the balloon protection. But it's really very helpful to have the balloon, because you have then easily an under pressure. The patient might also react, because when you pull out too much blood in a too short time, then he has no blood left in his brain. And also that is something which you have to consider. So don't be too aggressive with too much blood pulling out. Okay.
Perfect.